Spinal Muscular Atrophy, or SMA, is a genetic neuromuscular disorder, meaning it affects neurons and muscles in the body. SMA causes neurons in the spinal cord to die and the muscles connected to those neurons to atrophy, meaning to get smaller and become weak. When you want to contract a muscle, the brain sends a signal through an upper motor neuron to the spinal cord, then through a lower motor neuron from the spinal cord to the muscle, forming a neuromuscular junction. Alpha neurons are lower motor neurons responsible for voluntary contractions of muscles, and these are the neurons that die in SMA. When the alpha neuron dies, it stops releasing neurotransmitters into the neuromuscular junction. As a result, the muscles cannot contract, leading to atrophy over time. This loss of muscle leads to many signs and symptoms of SMA. This includes muscle weakness and decreased muscle tone, limited mobility, delayed gross motor skills, such as crawling or walking, contractures, which lead to deformed and rigid joints, and scoliosis, which is curvature of the spine. Patients may also have difficulties breathing, chest infections, or difficulty swallowing. It is important to note that SMA does not affect cognition, emotional development, or learning ability. So what causes SMA? Because SMA is a genetic disorder, we can find the answer on chromosome 5's survival motor neuron 1 gene. A loss or mutation of homologous copies of the SMN gene causes SMA. This mutation interferes with the production of functional SMN protein, making non-functional or no protein instead. The SMN protein is part of a group of proteins called the SMN complex, which is crucial for the maintenance of motor neurons. SMN protein is found throughout the body, with highest levels in the spinal cord. The SMN complex is required for the assembly of spliceosomes, which mediate splicing during RNA processing. This is essential for pre-mRNA to become mature RNA, ready for translation into proteins. The SMN complex is also important for the development of dendrites and axons on nerve cells, which are required to pass signals from and between neurons. The SMN protein is particularly important for motor neurons, however the exact reason is unclear. Without the SMN protein, motor neurons degenerate and die, leading to SMA over time. The good news is that the neighboring SMN2 gene can partially compensate by making some SMN protein. The SMN2 gene is a paralog, a copy of the SMN1 gene that arose due to gene duplication. The SMN2 gene is 99% identical with the SMN1 gene, with a single point mutation called C840CT. This means the 840th nucleotide has changed from a C in SMN1 to a T in SMN2. The SMN1 gene produces full-length mRNA with exon 7 included. However, the mutation in the SMN2 gene causes the exclusion of exon 7 from the majority of SMN2-derived mRNAs. When translation occurs, instead of making 100% functional, full-length SMN protein, the SMN2 gene produces a truncated, non-functional protein about 90% of the time. Therefore, only 10% of SMN2-derived protein is functional, which is too low to sustain the body alone. Nevertheless, the little amount of SMN protein that is produced is beneficial in SMA patients who have non-functional SMN1 genes. However, it turns out people can have from 0 to 8 copies of the SMN2 gene, which is why varying types of SMA exist. The types of SMA range from type 0 to type 4, which go from severe to mild. The severity can be attributed to the number of SMN2 copies the patient has, ranging from fewer copies to more copies. This is because the more SMN2 copies a person has, the more functional SMN protein is produced to maintain healthy motor neurons. Therefore, there is an inverse relationship between SMN2 copy number and disease severity. The more SMN2 copies a patient has, the less severe the SMA course likely will be. The types of SMA vary by severity, age of onset, symptoms, and life expectancy. Type 0 is the rarest and most severe form of SMA. It affects the baby even before birth. The fetus is less active in the womb and is born with abnormal breathing, severe weakness, and difficulty swallowing. SMA type 0 can be fatal before birth and most likely fatal within the first year of life. Type 1 is the most common, and it is diagnosed during an infant's first 6 months. Symptoms include floppy limbs and having a hard time swallowing and breathing. Infants with SMA type 1 can never sit. Type 1 progresses quickly, usually leading to death by the age of 2. In patients with SMA type 2, symptoms usually appear between 7 and 18 months. Children with SMA type 2 can never stand. Life expectancy ranges from early childhood to adulthood. Type 3 SMA is more mild. Symptoms first appear from 18 months to early adulthood. Patients with type 3 SMA can stand and walk, but may have trouble standing up from a sitting position. Most patients have a life expectancy close to normal. Symptoms for SMA type 4 don't emerge until the patient's 20s or 30s. Symptoms include slowly progressing muscle weakness, and life expectancy is normal. Because SMA is a genetic disorder, it is inherited between generations, following an autosomal recessive pattern. This means that a child must inherit 2 mutated copies of the SMN1 gene, one from each parent, to have SMA. SMA is the leading genetic cause of death in infants, affecting 1 in 10,000 live births. This translates to around 10,000 to 25,000 affected children and adults in the US. 1 in 50 Americans is a carrier. This can be calculated by multiplying 1 over 50 times 1 over 50 times 1/4, which equals 1 in 10,000, since there is a 1/4 chance that 2 carriers will have a child with SMA. Currently, there are 3 FDA-approved treatments for SMA: Zolgensma, Spinraza, and Evrysdi. Zolgensma is given to infants under 2 years old as a one-time intravenous injection, which costs $2.1 million. Spinraza is available to patients of all ages and administered every 4 months as an intrathecal injection into the spinal canal. After the first year, when the cost is higher, Spinraza is priced at $375,000 per year. Evrysdi is given to patients 2 months and older. It is a daily liquid medication taken by mouth or feeding tube. The price varies by weight, but caps at a maximum of $340,000 per year. Spinraza was the first to be approved in December 2016. Zolgensma was approved in May 2019, and Evrysdi was approved in August of 2020. So how do these different treatments work? Zolgensma is a gene replacement therapy which delivers functional SMN1 genes to motor neurons. Zolgensma is made up of 2 parts, the gene and the vector. The gene is a functional human copy of the SMN1 gene. The vector is made from adeno-associated virus 9, or AAV9. The viral DNA is removed and replaced with the SMN1 gene. The special proteins on the surface of AAV9 have high tropism in brain and spinal cord cells, which allows AAV9 to transduce motor neurons. When Zolgensma is released into the blood, the vector will inject its genome into motor neurons, and the SMN1 gene will sit inside the nucleus. This gene will then be expressed, making functional SMN protein to maintain the health of the motor neuron. The SMN gene does not become part of the patient's DNA. But because neurons don't divide, the SMN1 gene will not get lost over time. This is why Zolgensma can be a one-time dose, unlike the other 2 therapies. The next treatment is Spinraza, which targets the SMN2 gene to increase production of functional SMN protein. Spinraza is an antisense oligonucleotide, a short sequence of nucleotides that can bind to RNA to fix splicing errors. Spinraza binds to SMN2 pre-mRNA just after exon 7 and blocks a signal that usually cuts off exon 7. This allows the mature mRNA to be full-length and code for functional SMN protein. As a result, Spinraza works to correct the effect of the mutation on SMN2 genes, producing increased levels of SMN protein for the cell. Evrysdi is the most recently approved therapy. It works similarly to Spinraza by correcting the splicing of SMN2 mRNA. The difference is that Evrysdi is not an antisense oligonucleotide. Instead, it is a small molecule splicing modifier. This is why Evrysdi can be dosed orally, a key advantage over the other two therapies. With all three therapies being only a few years old, it is still too early to measure the full efficacy of each. However, clinical studies have shown all three therapies to improve motor function in type 1 SMA patients, including the ability to sit independently for at least 5 seconds. These treatments are continuing to be studied in patients up to 60 years old with types 1, 2, or 3 SMA. It is amazing how much medicine has progressed over the last 50 years. Advancements in gene therapy have allowed scientists to target the roots of genetic diseases. However, there is still more room for improvement. Current biotechs are working on optimizing viral vectors to overcome limitations of naturally occurring AAV serotypes, including improving antibody evasion, tissue targeting, transduction efficiency, and manufacturability. Another prevailing issue is the high cost of treatment due to the expenses of drug research and development. Luckily, all of us can support continued research to help SMA patients by donating. Please consider donating at curesma.org. To learn more, visit smanewstoday.com. Thank you for watching.